My name is Jawad Butt and I'm a medical doctor at the Department of Cardiology, Copenhagen University Hospital, Hospital in Denmark. So this study is important for several reasons. First of all, we know that patients with heart failure and PAD, that is peripheral artery disease, that these patients have a significantly worse prognosis than patients with heart failure without PAD. In other words, patients with heart failure and PAD is a very high-risk population. Therefore, we need effective therapies to reduce the risk of heart failure hospitalization and cardiovascular death in these patients. In addition, we know that with certain SGLT2 inhibitors, that is with the Dapagliflozin, that it increases the risk of amputations in patients with type 2 diabetes at high cardiovascular risk. At least that's what we saw in the CAMAS trials. However, this finding has not been replicated in other populations or with other SGLT2 inhibitors. And therefore, it is important to also examine whether this holds true in a heart failure population. This is in particularly interesting because patients with heart failure, all of them at least most of them at least receive diuretics, and we know that diuretics is also associated with an increase. So this was a patient-level meta-analysis of the DAPA-HF and DELIVER trials. So both of these trials enrolled patients with heart failure, that is patients who were symptomatic, who had a NYHA class 2 to 4, and these patients had to have a high or an elevated NT-proBNP level. So the principal difference between these two trials were that in DAPA-HF, patients were enrolled if they had a reduced ejection fraction, whereas in DELIVER, patients were enrolled if they had a mildly reduced or a preserved ejection fraction. So actually this is a trial, or these two trials covers the entire spectrum of patients with heart failure. The study design, both of these trials were phase 3 randomized clinical trials, and both of them randomized patients either to the SGLT2 inhibitor Dapagliflozin or placebo. And the primary outcome in both of the trials was a composite of worsening heart failure or cardiovascular death. So the data that I've presented here shows quite a few things. First of all, we now know that Dapagliflozin is effective in reducing the primary outcome, that is the composite of worsening heart failure and cardiovascular death, as well as each of the components of the primary outcome and all-cause death and total heart failure hospitalizations compared with placebo. And this beneficial effect is not modified by PAD status. That is, that the beneficial effect is seen in both patients with and without PAD. And the second and probably more interesting finding is that the risk of amputations is not increased with Dapagliflozin treatment as compared with placebo. Importantly, this was the case in both patients with and without PAD. So the take-home message of this, well, I think there are two take-home messages. First of all, we know that patients with PAD are a high-risk population, so we now know that, well, Dapagliflozin is an effective treatment in these patients, which means that they have a higher absolute risk reduction. So that's the first main thing. So it's an effective therapy. And the second take-home message is that Dapagliflozin is a safe therapy, especially when it comes to the risk of amputations. So the next steps of this, I think, is, so now we have established in several publications that Dapagliflozin is a safe and an effective treatment in patients with heart failure across the entire spectrum. So the next step, I think, is that now it's time to implement the treatment in the clinic.